Okay, so talking about trauma-informed care today, a lot of this is going to center on Hawaii because that's most recent stuff that I've been doing, but I think can really be applicable to most any marginalized population because I think there are a lot of similarities there. So. As you mentioned, Dr. Drexler, I did start a nonprofit called Hawaii Mental Health or Hawaii Behavioral Health Connection, and that really stemmed out of the wildfires that happened a couple years ago on Maui. So just to give a little background on this, when we are actually, I'm going to move this slide into a different slide. Okay. So really, if we're talking about Hawaii, in that early 1800s, we have the first Christian missionaries arriving in Hawaii, settling, and kind of changing the landscape of not only the the earth, not only the islands, but the people and how we understand indigenous, practices. And so, of course, with the settlers coming in, a lot of Native Hawaiians and local folks are displaced. The Native Hawaiian population is severely decreased and marginalized even further when a lot of the lands are kind of taken. As we move on, the military starts to recognize Hawaii as a military outpost. In Hawaii, there are 14 military bases. 11 or 12 of them are on the island of Oahu, which is one of the smaller islands. So you can imagine having a huge military population there, how that might also impact the local population. So interestingly, though, indigenous and native folks make up a disproportionately large number of military personnel. And this is for a lot of different reasons, but part of it is because of the connection to the land, right? So even if they are being, legislated against, literal laws being written against indigenous and native folks, it's still their land that they want to protect, and they feel that very deeply. And so you do see a large overrepresentation of Native populations in the military as well. So just to give a little more background here, Waikiki was the first capital of the Hawaiian Kingdom. In the 1800s, only the royal family were allowed, or folks associated with the royal family. And in 1901, the first hotel was built in Waikiki, originally as a royal retreat, but later on expanded. So this was the first hotel. If you're familiar with Waikiki at all, this is now the Moana Surfrider. Um, then the Royal Hawaiian Hotel was a second one built. That's the famous pink hotel on the beach there. And this was built with the Matson family, who are a shipping family. And if any of you have been to Filoli, Filoli was part of the Matson family. So the daughter um, was the was married I think he was a senator, or and they built that mansion, and that's where they lived. So interestingly, right next door was the Spreckles family, which is also connected to Hawaii. They were sugar plantation owners. Anyway, so Royal Hawaiian Hotel is completed. This is used during World War II as an R&R center for the military. And then post World War II, Waikiki became well known through movies, especially starring Elvis, and became sort of this playground for people, or what was known as a playground, and then the hotels just proliferated from there. So you can see up here the top black and white picture, 1920s of Waikiki. There's a lot of open land, right? And only these two hotels. And then the bottom picture is a more recent photo, and you can see all of the sort of spots that are flat-ish are completely covered by houses or condos or apartments. So Very, very populated, Oahu especially. So this spilled over into Maui, which is another island that's a few hundred miles away from Oahu. So here is where a lot of sugar plantations were planted. And for those of you who are
Let,
familiar
let
with
me let me just bump in for a moment.
yeah,
Someone's saying you are seeing the slides. Okay, sorry.
okay, that's all right. Um, okay, great. Sorry, I wasn't monitoring the chat there.
Oh, that
Um, all good?
all
Slides are
good.
good?
We'll
Okay,
we'll 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 monitor that for you so you don't
okay,
have to.
great.
Sorry.
No, no worries. So if you're familiar with Lahaina at all in recent years, before the fire especially, it was very built up, dry, right? Kind of hot area. But before all that happened, they were actually wetlands. And the crop that was one of the crops primarily grown there were the ulu trees, which are breadfruit trees. And so it was a very wet environment. There was a big natural uh, um, um, lake here, pond here, a fishing pond here. And then once the plantations started being built around, they diverted the water away from this area, which made it very arid. And then, of course, once the plantations went away and tourism became the new business, then resorts and golf courses started springing up, and so water was further diverted to those places. And just a couple years ago, there were messages being put out by the government saying to residents of Maui that they needed to limit their water usage so that the hotels would have enough water. So residents were not allowed to water their lawns or wash their vehicles or things like that, so that tourists would have water in the hotels and on the golf courses. So top painting is of what Lahaina used to look like, and a photo in the middle there, and on the bottom after the fires happened. So the fires, August 2023, August 8th, one of the deadliest wildfires in modern history. Over 100 people died. Most of them were older adults. And part of this was because there were a lot of apartments where older adults lived. Most of them didn't drive. And this is a very densely packed area of a lot of buildings, and people just couldn't get out. If any of you saw videos from people posting live during the fires, it was pretty terrifying. The cars were just completely packed. There's one road in, one road out, and people were just stuck in the roads with fires burning up around them. So even after the fire, a lot of people stayed in place amongst the rubble and toxic ash that was there. It was really hard to have people leave, especially older adults who this was their ancestral land. For some families, they've been there for 30 generations on that same property, and then they're being asked to leave. So over 12,000 people were left homeless. At, at the point when I made this slide, which was last year, 4,000 people, over 4,000 people had left. It's probably more now, and there's ongoing stuff, but I won't get too much into that. So during that time, we had all these different national and federal organizations coming in to help. They required all sorts of identification, paperwork, so on, that most people didn't have, right? Because it had burned up in the fire. And for older adults, they didn't have digital files. For a lot of local older adults, they didn't even have money in banks. They just had cash hidden around their houses. And one of my mentees, who's a native Hawaiian grad student, told me that when her grandmother passed and they cleaned out her house, they found $40,000 in cash hidden all around the house. So you can imagine for some of these older adults who already had, right, historical distrust through all those things that happen, now losing everything and then being told, oh, we can't help you and we can't help you recover anything. You don't get anything because you can't prove who you are, because you don't have money or things like that. How much more traumatizing that would be. There was a lot of confusing messaging that was happening at this time. Things were changing literally hour by hour. Policies were changing by day. So it was very confusing to everyone involved. And those of us who were trying to help were trying to keep up with all the changes happening, but it was very difficult. Assistance was only available to legal residents, at least through FEMA, through the federal organizations. A lot of the hotel workers are undocumented people from the Philippines, and they lost everything because they all lived in those areas. And so, it was just a lot of folks who were affected, not only losing their homes, not only having their lives threatened, but now not being able to be helped, right? So a lot of compounding traumatic things happening. So we had a lot of cultural clash happening, folks coming in, well-meaning folks, right, who are volunteering with the Red Cross or other federal groups were coming in, but some of them were literally seeing this as a paid vacation. I overheard some Red Cross workers asking survivors where the best place to go eat was, which beach should they go to, and these are people who just lost everything, being asked where they would recommend these people to go on vacation. So that was really difficult to hear. And I gave that feedback. So I was involved in a lot of the meetings with these federal groups. And, I gave that feedback not very kindly that a lot of volunteers were re-traumatizing people. And then you had all these grassroots organizations that were popping up with services meant for survivors and residents, whether those were like free food, right? Like kind of food pantries popping up. In a lot of the public parks, they literally called it the Kanaka Costco. So Kanaka Maoli is Native Hawaiian in Hawaiian language. It's actually people of the land, but so you had these pop-up resource centers meant for survivors, and volunteers were coming and taking stuff. There were services such as Lomi Lomi, which is Hawaiian massage therapy, herbal medicine, that kind of stuff. And volunteers were coming in and taking those slots for those services, acupuncture, massage, etc. So this was, of course, a huge problem as well. So then on top of that, you have these new volunteer organizations that were really opportunistic and predatory, preying on survivors. You had certain groups, such as religious groups, that were withholding services unless people were willing to join their church or whatever. And everything was very disorganized, right? Because it was very chaotic. So on top of that, once we sort of started getting a system going, when survivors were coming to ask for help, they were being accused of trying to scam the organizations or steal or get something. When they were explaining the things that they needed, and also understanding that in Hawaii, a lot of people live in multi-generational homes, right? So you have 3 or 4 generations living together. You have 10, 15 people living under one roof. And for some people, that's very difficult to understand. And so when residents were coming and asking for resources for more than 2 people, they're being accused of trying to steal. And then you have FEMA folks who are discounting their needs. And a lot of the hotels were shelters for these survivors, and people were being split up from their family unit that all lived together. You have mothers of new babies who rely on help from the grandparents for the older kids, and the grandparents are literally on the other side of the island while the parents and babies are in a hotel in a different place. So it was very, very difficult in that way. Some of the hotels were some of the more locally owned, managed hotels were very understanding, but some of the more international hotels who just did not understand this were very restrictive. Like survivors weren't allowed to be out of their rooms for more than just like going to and from getting, food or whatever. They weren't allowed to sit outside on the grounds or anything like that because the hotels still had guests in them. Um, so they didn't want to disturb or traumatize the guests with the fire survivors. So there was a lot of discrimination that was seen there with them. So, all this to say, when you already have a population that has this historical trauma, right, that are being, uh, displaced, being marginalized even further through historical situations, and then you have like a natural disaster on top of that, that just compounds, re-traumatizes, reminds, makes people feel less than, makes them feel even more distrustful of systems that are supposed to be helping them, but oftentimes aren't, right? So, how do we, as mental health providers, address all these things? How do we help these folks and help to build that sense of trust, right? So one of the frameworks that I use is decolonizing or liberation and liberation psychology for these folks. So for example, in this particular article, there was a really great quote in here that the field of psychology is based on 5% of the human population, and yet somehow we're supposed to apply this to 95% of the population, right? Psychology built on white male European standards doesn't really work in a lot of ways for the, native, indigenous, and collectivist societies, right? So decolonizing is really analyzing, understanding how those sort of frameworks or those parameters don't necessarily work and often pathologize normal things for other folks, right? Through history, Native and Indigenous folks have been seen as savages who are weak of the mind, who are somehow inferior, and that Europeans are intellectuals and superior, right? So having that standard already sets anyone who doesn't fit that mold down here, right? So being able to understand that, marginalizing, losing cultural and psychological contact with both traditional culture and larger society, that completely happens for Indigenous folks and for a lot of other folks who don't fit into that. Um, for example, in the US, we had the Chinese Exclusion Act, literally a law against Chinese, but probably at large anyone who is Asian, right? So being able to recognize those things, being able to address those things when you're working with these folks, um, being able to sit in that and recognize these are the systems that have impacted your mental health and your personal relationships with your family members, probably their relationships with their next generation up, and so on, and how all of these things have created this system under which people tend to experience trauma. So, through this lens and transformative justice or change that emphasizes local agency and resources, the prioritization of processes rather than preconceived outcomes, challenging the unequal intersecting power relationships and structures of exclusion at both the local and global level goes a long way, right? Being able to acknowledge that these systems are in place, being able to recognize that it's not you. You didn't make this up, right? You didn't make up these situations that have happened to you, or you didn't make up this oppression or marginalization that's happening, that this is existing in our ecosystem. So being able to recenter your client's voice and their experience, being open to what their experience is, even if that's not your own experience or not something that you are immersed in, being able to let them have that voice and reclaim that power, right? Recognizing that for a lot of marginalized folks, being able to connect with their community is healing. So, transformative justice seeks to redress and deconstruct conditions of systemic violence and marginality at multiple structural levels within society. So, understanding that we are in community with other people, with our neighborhood, our neighbors, as well as for especially Indigenous folks with the earth itself. For most Indigenous societies, we see the earth as a living relative, right? It's not just a thing or something that we live on, it's part of us. And recognizing it as a relative means we also have to take care of it. And if the earth that we live on, whether that's our local place or at large, is sick, then we are too. So being able to maintain and restore that balance between physical, mental, spiritual, and emotional aspects of being is always in the context of the collective, right? It's always within a bigger context. And so for folks who are marginalized, that may be something that you want to address. Um, so am I coming up on time or should I keep going?
I think we're gonna maybe have to move on, unfortunately, but
Okay, all right.
Well,
I'm sorry. Oh, okay.
yes.
Am I good on time? Keep going. We're at like 20,
Yeah,
21.
I think if you take just another minute or so,
Yeah,
I think we
okay.
move there. Yeah.
Not a problem. Okay. So basically understanding that development is not linear, right? And progress is not linear. I think this is true for any client that we're working with trauma. There's a lot of times where we may feel like we're progressing and regressing, and that's okay. Allowing for that, right? None of that uh, healing or progress is straightforward. We may have to regress or contract into our emotional state and recognizing that once we kind of get back to that and process through it, we can move on. So understanding that piece of it, and especially for marginalized communities, it's not just the ABC kind of thing. We have to be able to allow for that ebb and flow of healing. So yeah, that's all I'm going to say for today. And I'll stop sharing my slides. I'm happy to answer questions when we get to that question and answer phase of things. Thank you for my quick.
So thank you so much,
No
Dr.
problem.
Johnson. And I just want to point out that Daisy Alcaraz mentions that a lot of locals went back to their burnt homes to look for small belongings.
Correct.
Her friends,
Correct.
and she was there during the fire, did so, and she feels that some of the rescue folks actually spent more time at the Kaanapali Mall than they did helping. So, yeah.
Correct. Correct. And I'll talk about, I can talk more to that later
All
too.
right.
Yeah.
So, okay, so we do need to move on. So, Dr. Maguen, so thank you for your patience and wonderful to have you here and really looking forward to your talk.
Thank you so much. I will go ahead and share my slides. So let me go to slideshow and oops, here. Okay. Can everyone see the slides?
yes. Yes.
Perfect. Okay, wonderful. So today I'm really looking forward to presenting about moral injury. I'm going to define moral injury for us. I'm going to talk about measurement and how we measure it, prevalence, and also a little bit about how we have been thinking about treating moral injury. So I'm going to first start by just sharing that I'm a clinical psychologist by training myself. And I really wear many different hats. And so for me, this work started when I was working at the Boston VA. I started working there right before 9/11. Literally a few days before 9/11, and then after 9/11 we started sending people to wars in Afghanistan and Iraq. And so I was there when all of that unfolded, and was, in the clinics, having people come back and talk about their experiences in war over several years. So that really shaped a lot of my thinking. And for me, this is really important. My clinical work speaks directly to the research that I do. So what we were seeing during that time is a lot of people were coming back and we were giving them traditional PTSD treatments. And what we were seeing with the veterans is that sometimes that didn't go far enough, and that really what they were struggling with were some issues around the impact of killing in war, things that they did in war as opposed to things that happened to them, right? So this was really pivotal for me, hearing directly from the veterans and their experiences. And so that's really when I started becoming very involved in doing research and starting to think about moral injury. And this is a definition that grew out of um, that experience. And so we, big group of us collectively came up with this definition in 2009. And this is the moral injury definition. I'm going to kind of break it down because I think it's very, very important to kind of understand. We now hear moral injury thrown out a lot in the news and in different locations. And I think it's really important to kind of understand and define it really clearly. So moral injury really is when you do something, you fail to do something, or you witness something that goes against your moral beliefs and expectations. So there has to be some kind of a crossing of a line that happens for the individual. And they have to feel like they have transgressed in some way. They've either seen something or done something that crossed a line. And then betrayal can also play a really important role in moral injury. So, to kind of break it down, moral injury really requires two components. So you have to have an exposure to what we call a potentially morally injurious event, or we also abbreviate that as PMIE. And then there have to be symptoms that result from this exposure, right? So those two pieces, very similar to PTSD, right? With PTSD, you have to have the traumatic event and then the symptoms that follow. So just so moral injury requires these two components. So I want to kind of talk about what are some potentially morally injurious events. So, for me, the one that I study most is killing in war. When we first started doing a lot of this research and a lot of this work, there really wasn't much literature out there and many studies out there about killing in war. So we really talked to veterans directly about their experiences killing in war. And so that's, this is when you do something, right, that goes against your morals and values for many people, or you fail to do something. So for many veterans that we talk to, especially if they're medics or in the healthcare part of the military, they feel like they failed to save people and therefore they killed them. Maybe they were taking care of too many people, they couldn't save everyone. And that really for them was their potentially morally injurious event. And then, of course, you witness so many different things during war as well. That really sometimes people see things and maybe didn't intervene, or they saw things that really went against their morals and values, and that can be a very important part of starting the moral injury cycle. So I want to just share here because I think that the term moral injury gets used when sometimes people are referring to moral stress or moral distress. So I think about moral injury really on a continuum. And so moral stress is when you're exposed to a situation that potentially is a moral dilemma or something that you're really struggling with, but you may not have long-lasting symptoms, right? So it's something that you may experience in the moment. You see something that happens, it's upsetting to you, but over time you may have conversations and talk to people and resolve it. Moral distress is when you start to feel some distress, but maybe your day-to-day functioning is not affected. And sometimes moral distress can be turned into, something like you take the distress that you're feeling and you turn it into activism or conversation. So it can be sort of a starting point that people really use to deal with what they're experiencing. And then at the far end of the continuum, we have moral injury. So that's really when you have more intensive symptoms and your functioning is more impacted. And I'm really going to talk in just a little bit about the symptoms when I talk about how we measure moral injury specifically. So another huge question that I get asked is like, is moral injury really just a subtype of PTSD? Is moral injury, something that should be its own thing, or is it part of PTSD? And I would argue, and I argue here, that really these are two separate phenomena. So PTSD is really a diagnosis, right? So we know that with PTSD, people experience trauma, there has to be exposure, and they have very clear symptoms, re-experiencing symptoms, avoidance, emotional numbing, etc. And then PTSD treatment is grounded in fear-based theories, right? And so you have to have an IED explodes, and then you're faced with having a lot of fear and distress around that, right? So that's PTSD. Moral injury is not a diagnosis, and I'm going to talk in just a little bit about some new changes to the DSM and how people are thinking about it now in the DSM. This is just hot off the presses, and I'm excited to kind of talk to you all more about this. But moral injury is not a diagnosis, and I think a lot of people argue that it should never be a diagnosis, right? And so there can be some people who feel like it should be in the DSM as a diagnosis and others who don't. And I would encourage you to kind of think for yourself about where you stand on this issue after you've kind of heard some more of this presentation, but I think it's a really important thing to think about. So moral injury really involves guilt, shame, loss, um, you know, inability to self-forgive. And so those are not directly PTSD symptoms, right? So this is some of the hallmark symptoms of moral injury are really based in the guilt and shame because of what people were exposed to, the kinds of moral injury events that they experienced. So oftentimes people with moral injury engage in self-sabotaging behaviors. They feel like because of what they did or what they experienced, they don't deserve to be happy. And sometimes as a result of that, they engage in self-sabotaging behaviors, including, unfortunately, a number of substance use behaviors as well. Moral injury spirituality is really key in moral injury. As I mentioned, self-forgiveness or inability to self-forgive is often something that we see pretty profoundly in moral injury. So I'm going to just present here a causal framework for moral injury that we introduced. And I'm going to go through this pretty quickly, but I encourage you, if you're interested, to look up this article that kind of takes a deeper dive. But for moral injury to occur, again, you have to have a transgression. There has to be some dissonance. And as I mentioned, shame and guilt are really the hallmark symptoms. So if you start to think about like, oh, I don't deserve to be happy, I did something that really went against my morals and values, you start to really feel guilty, and that really becomes also, shame becomes part of the picture. You feel like somehow you're less worthy because of what you did. Individuals with moral injury often withdraw because they feel like, if people knew what they did or what they didn't do, they would judge them. They would not want to be around them. And then failure to self-forgive is an incredibly important part of the clinical picture. And often that failure to self-forgive is where we try to intervene. In moral injury treatment. And then, as I mentioned, unfortunately, there's a lot of self-harming and demoralization. Oftentimes, people with moral injury often, have suicidal thoughts or, unfortunately attempt suicide sometimes as well in the most extreme cases. I'm going to talk a little bit about how often does moral injury occur. And again, I want you to keep in mind the two parts of the definition or the two parts of moral injury that I shared with you, both the exposure as well as the symptoms. So we did a study of 1,200 veterans, first responders, and healthcare workers. So we had a very large sample across health professions, across high-risk professions. And what we found is about 1 in 2 people in the sample endorse being involved in an event as part of their work that they perceive to be morally wrong. Okay, so that's the exposure, right? So 1 in 2 in high-risk professions, those 3 high-risk professions reported that exposure. However, only 1 in 20 participants screened positive for probable moral injury. So that's really important. So high rates of exposure, but 1 in 20 actually screened positive for moral injury. So I'm going to share with you what that screening looks like. So how do we measure moral injury? So we developed what's called the Moral Injury and Distress Scale, or the MIDS for short. This is available to all of you. It's freely posted on the National Center for PTSD website. It's available to clinicians, to researchers. It was developed as part of government work and is available to anyone who would like to use it. Again, it was developed not only in veterans, but in all 3 high-risk groups that I talk about, so also healthcare workers and first responders. And so I'm going to go through what the scale looks like. So we first asked about exposure. So I acted in ways that violated my morals and values. I failed to do something. I saw things. And with each of these, we asked about whether the individual is bothered by what they did. We then asked them to write a few sentences to describe the event that happened. We want to know what's most upsetting, what they wish they would have done differently, how often it occurred, and how long ago it occurred. And this is really to just, can be used clinically, actually, when we treat people, so we know more about what the event was. And also, it's really important that we keep this event in mind when we're asking about the symptoms. So I want to just kind of show you some examples that people, in the 3 high-risk groups shared with us. So I had to kill children that shot at us during patrol. That was a situation that was shared by a veteran. I was told to take patients off of ventilators that I thought could be saved. That's a healthcare worker. And I saw fellow police officers use excessive force and did not intervene. And that was a first responder. So these are just some examples of the PMIEs, or the exposures that people in these groups shared. So here is the list of 18 symptoms that make up moral injury. And again, we ask these in relation to that exposure, right? So you have to keep that exposure in mind. So in the first column, you will see the item itself, and then next you will see how frequently it occurred in these high-risk groups. And then finally, you'll see how did this hang together with all of the other items. So, I think about how I should have been able to do more. You can see that that's about 20% of the sample endorse that item. And you can see guilt showing up as a major symptom here. People feel like they have punished themselves. They don't seek support because they feel like they don't deserve it. They worry that others wouldn't understand. Several people feel betrayed by their leaders or their institution. And many feel like their spirituality or faith is no longer a source of comfort after what happened to them, their particular morally injurious event. So the next step in developing, after we developed the MIDS, we had to develop a cut score. So as we talked about before, it really, we want to make sure that we intervene with those who are suffering most. And a way to do that is by determining a cut score. And so we found that the cut score in the MIDS is greater than or equal to a score of about 27. And we get that score by adding up all of the symptoms, basically. And so this was really based at looking at a number of different measures, including those who screened positive for trauma-related guilt and functional impairment. And so we recommend that a cut score of 27 be used if you're working with people clinically or if you're using the MIDS in research. How am I doing on time?
So we are pressing it a little bit, but it looks like you have a number of important points to make. So please go ahead.
Okay, I will try to, I'm almost at the end, so I'm going to be brief. So I want to just share that there is a new Z code in the DSM. And the important thing is that Z code is not a diagnosis. It's an issue for clinical consideration. So it's, and here I wanted to show you specifically what was revised. So prior we had in the DSM a religious or spiritual problem, and we wanted, basically there was argument to add and connect moral problems specifically to this Z code. And so now the Z code, you can see literally the blue is what has changed. And so now moral problem has been added to moral, religious, or spiritual problem. And moral problems include experiences that disrupt one's understanding of right and wrong or sense of goodness of oneself, others, or institutions. So this is really important because it was put, moral problems on the map. To be really clear, this is not moral injury. So nowhere here in the revised text you see moral injury, but you see moral problems. So I'm not going to spend a lot of time talking about the benefits of the barriers, but we can maybe talk about that in the time we have together afterwards. But a question that I want all of you to think about is, does having a diagnostic option decrease or increase stigma for these populations, right? So that's something to think about. So I'm going to wrap up by talking about how we treat moral injury. And I want to be really clear that this is not something that gets done in a vacuum. So it's not just in a therapy room. Similar to our prior speaker, we think about communities, right? We want to know the communities in which the person is embedded. So cultural communities, spiritual communities, and we have to build bridges, right, in order to really treat the whole person and the whole individual. So, so this is really important in treating moral injury. Therapy is going to be one part of the picture, but it is, we have to connect people with a much, much larger community in order to heal, right? So I wanted to just in the last few moments, share with you that there are a number of existing treatments for moral injury that have developed in veterans. You can see here the list. So we particularly worked on the impact of killing treatment, which is 10 individual sessions. But you can see here there is a wide range of treatments that are in development and at various forms of testing that really span individual treatment, group treatment, and some even involve the community as well. So just wanted to wrap up with some information and resources for those of you who are interested. We have a moral injury fact sheet posted on the National Center for PTSD website, both just in general about healthcare workers. And so I'll sort of share those links. And then I just want to thank all of my collaborators. It takes a village to kind of do this work. And then if you're interested in this topic and want to email me, and if you have any questions, please don't hesitate to do that. I'm always really happy to respond to questions if we don't get to them today. So thank you. That wraps it up for me.
Okay, well, so thank you so much, Dr. Maguen. And I just want to say that this concept of moral injury has really helped to elucidate a piece of the picture that I think wasn't recognized previously. It's key to working with people who have PTSD, I think, and recognizing this particular area. So thank you. So we will move on just in the interest of time. So Reika Faust is here and is our next presenter, and really we're honored to have her. Reika Faust is an adjunct professor at Notre Dame de Namur University and an LMFT, LPCC in private practice in collaboration with One Life Counseling Center. So Reika Faust is also a program associate with the Leather and LGBTQ Cultural District, reflecting her ongoing engagement in supporting diverse and affirming community work. A proud NDNU clinical psychology alumna, so class of 2018. Reika Faust also holds a Master of Arts in Specialized Criminology from the University of the Rockies and is a certified telemental health provider, certified trauma professional, and certified in trauma-focused CBT, as well as a California State certified sexual assault counselor. Reika Faust's work bridges trauma-informed therapy, inclusive practice, and systems awareness, offering really rich insights into how MFTs and LPCs can create safe and empowering spaces for clients across identities and experiences. So please also help me welcome Reika Faust. And so I will turn it to you.
Thank you. Good afternoon, everyone. Thank you so much for having me. A little bit about my background, as Michael had shared. I have worked extensively within the trauma population. Most of it is within the sexual assault survivors. So currently, I've been in private practice for the last 2 years, but been clinical practice since graduating in 2018. My kind of niches that I find myself falling into now in private practice, the individuals that find me tend to be individuals that have been formerly incarcerated, as a lot of my clinical experience was while I was in the San Francisco County Jail, as well as the juvenile hall in San Mateo. I also have a lot of clients that are sexual assault survivors. Another kind of niche that I work within is ethical non-monogamy or alternative lifestyle practices. And over the last few years, many more of the clients that I see now are LGBTQ identified, myself included in that, which is something that is interesting to see as kind of current events are happening, that more individuals are trying to find like therapists that also identify in the way in which they identify in order to find some common ground. What I am going to go ahead and focus on first is I'm going to share a couple of statistics regarding sexual assault, and I'm going to ask us to just think about it for a moment. Okay. So every 74 seconds, someone in the United States is sexually assaulted. And every 9 minutes, that somebody is a child. It is estimated that 423,000 people ages 12 and over experience violence in the United States. 1 out of every 6 women will experience attempted or completed rape in their lifetime. 1 every 10 rape survivor victims are men. And incarcerated, there's 80,600 that are also assaulted annually. I'm just putting that number there for a moment for us to reflect on the fact that chances are, at some point in time while you are working, you are going to have somebody that comes through your office that is a survivor. And there are going to be a lot of things that come up with that. In working with sexual assault survivors, it's really important to remember that the feelings and experience that will come up within the room are going to be complicated, intense, and oftentimes very unclear. Individuals that have experienced sexual assault often have PTSD, depression, non-fatal suicidal behavior, self-harming behaviors, alcohol problems or substance abuse, eating disorders. It can also develop into personality disorders such as borderline personality disorder. Most individuals may have a difficult relationship with sex. This also means that they have difficulty with the relationships with themselves, but also with other people that are within their lives also. They often have maladapted beliefs. There's a perceived lack of control that they have. There's immense shame that is something that is going to be living in the room with you often, and a loss of self. So it's always very important that if you're working with somebody within this demographic, to be non-judgmental in your exploration in order to try to like identify or help with them identify the recurring themes or patterns that could be helpful in like resolving some of their trauma. And discussing the past is something that is going to be, as most of you will be very aware, it's going to be challenging to sit with. I'm going to go ahead and I just shared a little bit about sexual assault survivors because that's a big portion of people that you will likely encounter at some point in time during your clinical practice. I want to move for a moment to the LGBTQ plus community as well, because also this is another demographic that also experiences a lot of sexual violence as well. And so The LGBTQ plus individuals, they are 4 times more likely to experience violent assault than cisgender heterosexual counterparts. When I say experience violence, we're talking about rape, sexual assault, robbery, aggressive or simple assault. As a result, it's estimated that 48% of LGBTQ individuals and 42% of transgender and gender expansive individuals meet the criteria for PTSD. And there's a number of ranges that there are a number of things that are stressors for individuals within this. So obviously we have the assault component. We also have minority stress. This is discrimination and violent victimization. There's a lot of shame and stigma. There's also expectations of fear or rejection, especially from families, because there's also like a lot of cultural components involved as well. There is identity concealment, as in needing to feel as though they cannot be their authentic self with everybody within the world or within their even family circles. Sometimes there's a fear of coming out, or sometimes also there can be shame wrapped up in the idea of being able to pass and everything and have to live in that experience as well. There's also negative, oftentimes individuals within the LGBTQ plus demographic will have had experienced negative healthcare experiences. So often there's a lot of justification and defending that needs to happen when they're even just trying to access their own medical rights, right? And it's important to acknowledge like the cultural difference too. I think one of the things that many of the clinicians that I have worked with have found challenging is the fact that depending on which demographic that you're working with, you're also looking at different cultural norms. And if you're in a heterosexual paradigm, you're going to come into a therapy session with a particular lens of what you're working with. And it's not going to be quite effective or accurate because you don't know what that other queer experience is, right? And sometimes that can cause some harm within the relationship. One of the things that also is important to note with working in any kind of demographic that's experiencing trauma, I feel it's important to note vicarious trauma is something that as a clinician, you are going to experience. There have been a number of studies that, depending on which study you look at, it says 21 to 75% of clinicians in helping professions experience vicarious trauma, which means this is just due to the exposure that we have within the clinical room. You're sitting there listening to people tell you their darkest and most troubling things. And sometimes it's not like a normal 9 to 5 job where you can just click, go off, not have to worry about it. Oftentimes your client's stories stay with you, and it can also increase your own level of anxiety and make you feel compassion fatigue, burnt out. And so this is also very important that I'm going to say it's essential for any clinician to really have a very good self-care kind of routine of your own, something that you're going to be able to do to navigate the difficulties that it comes with working with populations that are hurt and wounded. Having good support systems, like consultation groups, are also amazing things to do. I think I recognize I went through everything very, very quickly because I'm also noting time. But one of the things that I would like to encourage us when we are in the room with clients is that our biggest attribute can be our curiosity around what it is that we're going into the room with. I wouldn't encourage anybody to go into with the assumption that you're going to know everybody's story, because everybody's story is going to be very, very different. And you are going to go ahead and come through in your therapy with your own lens of how you navigate the world. And that's not going to align with your clients sometimes. And so it's very important to be kind of culturally, humility is going to be very important. Like if you're working with somebody that you don't know anything about whatever background that they're coming from, it is on you to go ahead and do a little bit of research and education, because one of the things that I have seen and have heard from my own clients with working with clinicians is that it can feel very alienating for them to have to come into a room and feel as though they have to educate you about something that they're trying to get some support around. So be it queer community, sexual assault, anything at all, keep a very open mind. But when you're in the room and you hear something that you know that you don't really have a lot of knowledge about, it's important for you then to do your due diligence, to go research and get a firm grounding of what it is that you're trying to support them with. It's going to be important to understand your own biases as well when you're coming into the room, because we all have them. We're not blank slates. We really aren't. We all come into a room with our things. And gaining trust and working with individuals that have had a lot of traumatic experiences, oftentimes trust is something that is so very, very hard to gather and earn, and it can take some time. And I think that's really all I really wanted to share around that. But I do want to note that if there is any additional questions around any of the populations in which I do serve, I'm always more than happy to be a resource and connect, share information. I think it's very important to lean on your clinical networks in order to make sure that you're supporting yourself as well while you're doing the work in private practice, because it can be very isolating and feel like you're working in a silo. So I want to say thank you for your time.
Well, and thank you for sharing your wisdom and that talk with us. And I think one of the things you said that's extremely important is that it would be a rare practice in which sometimes people do not get seen who have experienced some kind of trauma, some kind of moral injury. So this is really key, I think, to so much of the work that we do. So thank you so much for that. So we have a few minutes now to open the floor for questions and discussion. I know there had been one observation that had come up already around the help that was being received in Hawaii, which we can kind of get back to if you like. I also, as we proceed here, I think one of the questions that's come up is that many organizations now label themselves as trauma informed, but evidence shows that implementation often stops with awareness training rather than any kind of systemic change. From your perspective, what distinguishes a truly trauma informed system from one that simply sort of adopts that language? How would we recognize it if we see it? I realize that's a difficult question, but any thoughts you might have, I'd love to hear.
Did you want me to answer that?
Sure.
Okay, well, first to address the question that or the comment in the chat, absolutely, Daisy, you're correct. There was a lot of issue with of the different volunteers who were helping on Maui. Like I said, not understanding the local culture, but also not understanding the historical context of, the families who had been there for many, many generations, walking through, the rubble of where the homes stood, where family members died. People were just walking straight through as opposed to giving, the proper sort of deference to what had taken place there. Um, so yeah, for sure, a lot of volunteers were treating this as a vacation. In terms of the trauma informed, that is a very, very deep question, I think. Um, for me personally, as a trauma therapist, and I do also like Reika, see a lot, like the majority of the patients I see have sexual trauma, and most of it is childhood sexual trauma. Again, those layers of trauma, intergenerational trauma, and especially for Native and Indigenous women primarily, there's a very large percentage who have been sexually assaulted, who have been the victims of childhood sexual assault. Um, for those who are in my cross-cultural class, they read an article about Alaska Natives, how it's so common that a lot of mothers just want to have on hand the um, day after pill for the eventuality that their daughters get raped. So that's how common it is. So if in terms of the trauma informed, yeah, taking a 2 hour training on or 2 hour training on what trauma is not sufficient. Oftentimes, and I've seen patients probably like Rika, people who've come to me who have been in therapy for something else and maybe said something about trauma in their past. and that person who has no trauma training whatsoever tries to work with them on the trauma and makes it so much worse, uh, to the point that they are distrustful of therapy. So I think it can be very, I know it's like very popular now to say you're trauma informed. And I think that can be very dangerous, right? Because then you're coming in from this perspective of not actually having knowledge and trying to maybe implement things that are not helpful at all, that may be harmful. Like Reika had mentioned, you know, doing that work, that background work to understand what this means for folks, and really having a knowledge base, more than just a couple hours of like overview of what is trauma. To yeah, to that those are that's my unedited, not very deeply thought out answer.
Pretty good answer. I think just sort of picking up on that, I think you're saying that, well, maybe that training is important. What's also really required is sort of supervised clinical experience or consultative experience, if you are already licensed, would be added to that. Rika, Shira, anything to add to that one?
Actually, I think one of the things that came to mind while I was listening is the fact that I shouldn't make the assumption that most clinicians or most helping professions are often here because we ourselves have some sort of traumatic history that we are navigating, right? Like something we've been touched by it in some kind of way. And I think part of being also trauma informed in your care and practice is being able to really know that you've also done the work yourself to navigate your own healing. Because the last thing you want to do is be working with somebody, have someone share something that might touch on something that is close to your own trauma. You become activated, and now it is no longer about your client, right? And being able to really do that work, which I'm going to encourage everybody that's in your graduate program right now, that's part of what the program's for, is for you to really go through your own stuff, have a firm grasp about it, and also learn how to create boundaries for yourself and in the work that you're doing with clients. And so I really do believe that's part of the trauma informed care process, is just knowing yourself, having your boundaries, knowing what is your activation, what is your client's stuff, right? That's going to do you a lot of good, and will also help you from not burning out, because it's it's a difficult beast doing trauma work.
Yeah, I definitely agree with what's been said. And I'll also add that, consultation is so important, Michael, as you mentioned, some other people brought up too. So it's a huge strength to be able to know what your limitations are and to seek out other people, trusted others, to just sort of say, hey, I have a really hard case. I want to run this by you. And that's a strength. It's not a limitation, right? And so if you can hold on to the many nuggets that were shared here, but that too, like I think that you have a community. So lean on that community, be able to reach out to that community. That's so critical. It helps us all grow, as therapists. So um, the other thing that I'll mention is I think, I work in a system where, we're mental health professionals, but our primary care, professionals are also often coming to us too, right? Like people usually show up first many times to their primary care doctors, and this is where a lot of this may emerge. And so I think it's not only, necessarily us doing the consulting, but being open to others coming to us and sharing maybe our experience as well. So I think it goes both ways too. So
So thanks so much. So, and several things that each of you have said, just to make me think about another question. People are a little interested in that concept about the provider experiencing their own moral distress, injury, or PTSD in a vicarious fashion. And I wonder if perhaps if we've not done that own work, our own work, and that trauma or whatever that distress is still reverberating around for us, maybe that makes us even more likely to experience that vicarious trauma. I'm not sure about that. But that seems like it might be a possibility. So I think we're really getting down to time here, but I think could each of you share, Rika, you did a little bit, but would you mind sharing what would be your suggestions beyond the consultation about that self-care? Any other pearls of wisdom around that?
Well, I'm a huge person that believes in like somatic work and everything, and trauma is stored in your body. So I would say having a very good somatic practice for yourself is something that could be very beneficial and grounding, and just and also really being able to find ways that work for you, that when you're no longer in your chair with your client, that you're able to go ahead and put that aside and remember to live your own life and to be connected with the people that you are connected to, right? It's going to be difficult at times. Like I know there have been plenty of times in the work that I've done that, especially working with children, I'm a parent myself, and then I interact with my kids, and my heart just breaks to think of someone their age doing something, like going through something, and just appreciate the blessings that you have in your life, right? Like always try to find the things that are really fueling you, because it can be very depleting sometimes working in this.
Yeah. I second everything that Rika just said. I'm a big proponent. All my students have heard me say, get your own therapy, right? Get your own therapist. For me personally, if your therapist doesn't have a therapist, run away. That's what I tell my students. Because that's a problem, right? If you don't know the things that are triggering you, or you don't know where your blind spots are, that's a big problem. You can make your your clients' issues a lot worse. And also the somatic work, getting outside, doing stuff that fills your cup back up, or your bucket, whatever you want to call it. My students know I'm a horse person, so every single day I have to be at the barn for a couple hours every single day. Because the work we do is heavy, right? You're talking about people who have experienced really horrible things, um, and they're holding it, they're dealing with their own stuff, but maybe this has happened to their siblings too, or their parents too, or their children too. And so they're having to hold it all. For a lot of the folks that I see, they're the first person in their family to get therapy, and because most of them are indigenous, there's a real distrust of this system. And their family members all think that something's wrong with them, that they're talking to someone outside the family about their problems. But they're like, I've never told anyone in my family what I experienced. Once they sort of process through it, maybe there's one close family member they're willing to share it with, and all of a sudden that family member is like, that happened to me too. And then it's another, it's like, whoa, this is systemic, right? And so yeah, so doing that personal work, doing that somatic work, whatever that looks like, if it means going hiking. For me, it's riding horses, being around horses. I also utilize horses for trauma therapy. All of those things are so important to take care of you, because it can be very heavy. It can be extremely rewarding, but it can be extremely heavy too. And same working with veterans, same thing. I had a lot of veterans with moral injury, and I worked with quite a number of special ops guys, which is a totally different category than your typical combat vet. So yeah.
I will just add too that we're very good about, as therapists, taking care of other people, right? So giving yourself that same grace is just so important, right? Sometimes we just need to listen to our own advice, right? And we forget that. So we know what we should do to take care of ourselves, and we know those things. So just make that time and space for yourself. It's so, so, so important. I'll also just mention a few things that have been very helpful for me. So I know when I'm seeing very difficult patients, things that are very hard for me in the room, I just think about my scheduling, and I think about my day, right? So I try to space things out. I try to give myself a little bit of time to take a few deep breaths, right, in between those sessions. Things like that can go a really long way. And then it's also, okay, we talk a lot in the supervision that I do or in my own work, like I know what my limitations are with things that are going to be hard for me in the room or triggering for me in the room. So it's okay sometimes to, if you get a referral and you know that you're not the best person, you don't have to be perfect, right? It's okay to say, I know someone really great who has expertise in this. And so just, I think knowing your own limitations and that we are all human goes a really long way.
Oh, thank you all so much for that. So, and I just want to just look at the floor and see, are there any additional last minute questions? Anyone have another question? Going once, a little bit like an auction. Yeah. Okay, so I think I want to say to the panel, and this I really mean, I am truly delighted with the presentation today. This is such key material. I think that really understanding what this means in today's world is extremely important. And I see, oh, Chelsea has many questions, but she wants to thank the presenters. Yes, well, and sometimes the one of the big benefits of any kind of presentation is that it gets people even more interested in the topic. And if they have even more questions, that's probably a good thing because we want to encourage everybody to really follow up on this. I think each of our presenters has said that they would be open to additional consultation or questions if needed. And so once again, I want to thank them all very much for this. And so let's give them a big round. All
I'd like
right.
to add too, you all followed a class today that we talked on quite a lot of some of the things you spoke about, including the value of integrative perspectives, the value of spirituality, the value of how we include morality. Um, and some of you named one of the biggest clinical tools I was talking about, so to speak, today, and that's of curiosity and continually learning. I always feel like that is such a big part of that self-care that you all were talking about. I'm reminded of a passage from Merlin from T.H. White, and he said the best antidote for being sad is to continually learn because it's the one thing that never fails. So I feel like you all three of you gave me a lot to learn from today, and a lot to our students as well that dovetailed with this idea of talking about working in a more innovative edge, which was what the class today that I was teaching was about. So thank you for your innovations and how it touched on so many areas. So just want to say thank you so much on that. So.
Indeed. Thanks again. And Dr. Liou-Johnson, yes. So I think we did not mention that, but you are also an adjunct professor at NDNU. And of course, many people here know that because they're in your classes, but I don't know that I mentioned that. So anyway, we want everyone to be aware of that. So anyway, once again, thank you so much, panel. Why don't we go ahead then and end? And you have really helped us a lot. Thank you.
Thanks for putting this together.
Thank you.
Thank you all.
Thank you.
Thank you all for attending as well, for
Yeah,
all in our
thank you.
community.